My name is Richard Gibbs. I'm a vascular surgeon at Imperial College London, and I'm interviewing Professor Michel Makaroun this afternoon, who is of course Professor of Surgery at the University of Pittsburgh and Secretary of the Society for Vascular Surgery. Michel, I want to talk to you this afternoon about the topic you spoke of this morning, which is embolizing lesion in the aorta. And you spoke about this today. What types of lesion can be treated by endovascular means, and what do you think the benefits are of this specific approach?
Well, the lesions in the aorta that can embolize to other parts of the arterial tree are two distinct natures. They are either atherosclerotic plaque that embolize small debris, or a form of thrombus that can be attached to the wall that can break loose and embolize distally. And we have found that actually both of them can be easily be handled by covering them with a stent graft and preventing the embolization from continuing. Because one of the biggest drawbacks of these lesions is that they have a high recurrence rate. And the traditional method for treating atherosclerotic emboli is a surgical replacement of the aorta that is embolizing, which can be quite a high-risk procedure in some of these patients because many of them have a compromised renal function with the embolization to the kidneys and have multiple other burden of atherosclerotic disease in the coronaries and a variety of other vascular beds. And the endovascular option is far less invasive and can typically be done in a relatively short period of time under local anesthesia and provide protection from additional embolization.
So Michel, what about the next level of complexity up, which is the treatment of thoracoabdominal thrombi and the shaggy aorta? When did you start doing that?
Well, the first case that we did was in 2006, and it was specifically in the distal thoracic aorta, and that is actually where about 80% of the atherosclerotic emboli come from, especially those that affect the visceral organs such as the kidneys. The ones that come from the infrarenal aorta are typically a little bit easier to deal with because you don't have to worry about the visceral segment that has the major branches to the aorta, and typically they're embolizing mostly to the toes. So the level of risk is a little bit lower. So we have done about 80% of the patients that we covered had a thoracic component involved. We typically do not address the visceral segment from the celiac to the renals with an endovascular approach and reserve still a surgical option for these patients.
Yeah. And what do you recommend in terms of imaging preoperatively?
Well, the diagnosis typically is simplest by a CT angiogram. The problem with CT angiogram is it clearly involves the use of contrast that may be not well tolerated by patients with compromised renal function. And we have found that ultrasound, especially TEE for the thoracic aorta, can provide a lot of information about the source of the embolization, which is usually the most difficult part of the diagnosis, is to try and identify what segment of the aorta is actually providing the source of the emboli. And we use the same technique during the deployment, where we actually use either intravascular ultrasound or TEE to identify the most unstable segments of the aorta, because by and large the entire aorta has some form of atherosclerotic debris that is potentially the source, but more likely than not is not contributing to the clinical picture. And the TEE and the IVUS are usually very good diagnostic and controlling imaging modalities to identify the exact part of the aorta that's responsible and the one that you're going to end up covering.
And do you worry about the passage of soft and stiff wires and the device in terms of actually knocking off and causing embolization of the lesion you're trying to treat?
Well, that's exactly the reason why people may shy away from this mechanism, and we were very nervous about using an endovascular approach to embolizing lesions. But after our first 25 patients, we have encountered essentially no clinical cases where we identified an intraoperative or perioperative embolization. So what we do is we do minimal manipulation. We decide based on the IVUS exactly what portion we are going to cover. We don't use contrast, we don't use angiography, and we just simply advance the device and open it, and avoid ballooning, and try to get out as quickly as possible. And we have been able to avoid clinical embolization as part of this.
Michel, you are secretary of the SVS this year. Can you tell us a bit about what's on the agenda for the SVS?
Well, the SVS has a lot of functions, and some of them may be of interest to you and some of them are not. The politics of practice in the United States are part of this, and I will skip that. The educational component, we have focused on developing new products for continuing education, and this year we released the new version of VSAP, which is a continuing education software that for the first time will be made available internationally. The other parts of the education is developing new courses that had been in existence prior to like the review course that was part of the UCLA group that now will become part of the vascular SVS mandate. We have focused on increasing the international nature of the annual meeting that we have in June. So there are several parts of the meeting this year that will be dedicated to international contributions. There's also been a increased component for funding research. So we have been raising funds to promote startup funds for major trials in the U.S. So we have been trying to increase the level of funding that we're providing for young investigators. We have also focused on the last year developing the Venous Journal that will be a sister journal to the Journal of Vascular Surgery. And we just started the cases journal that will be removed from the main Journal of Vascular Surgery and now be placed online, such as something that the European Journal has done previously. So this kind of gives you a little bit of a flavor about what the SBS gets involved with.
A busy agenda. What's been the highlights of the abdominal aortic day here at Charing Cross today for you?
Well, the interesting thing about Charing Cross and most European meetings is we get to meet a lot of colleagues from around the world who are experienced with technology that is not necessarily yet available in the United States. As you know, our regulatory pathways are a little bit more stringent, and we tend to lag behind the development of new products. Although they may be developed in the US, we don't get access to them until much later. So it's always good to hear the contributions of the Europeans and the Australians and essentially people from around the world. So the highlights of the day have been like the branch systems, the new aortic grafts that are not yet available in the US. It's always good to hear about them here.
Michel, what do you think makes the Charing Cross meeting stand out and perhaps be a little more special than all the other vascular meetings that go on in the calendar?
Well, as you know, it's you do end up seeing the same type of speakers and topics addressed at Charing Cross as many of the other meetings, but there's probably a little bit more focus on evidence and the background for supporting the adoption of certain techniques and devices in various parts of the vascular practice that we do. In general, there's a little bit less focus on how I can do it and more about why should I do it.
Very nicely put. Thanks very much.
My pleasure.